It's a pleasure now to introduce my other senior colleague at the Corinne Goldsmith Dickinson Center for MS, Dr. Fred Lublin, who is the director of the center and the Saunders Family Professor of Neurology at Mount Sinai School of Medicine. Fred is an internationally renowned authority in MS in general, but in particular with expertise in experimental therapeutics for MS. He's been involved in many clinical trials. Is the former chair of the Clinical Trials Committee of the National MS Society, and he's currently a member of the Board of Directors of the National MS Society and chair of the Clinical Advisory Committee for the New York City chapter of the MS Society. We've heard from Dr. Katz and from the speakers this morning about how most of our treatments, in fact, all of our current treatments, are aimed and indicated for relapsing forms of MS. But Fred is going to talk about hopes for treatment of progressive MS.
Thanks, Aaron, and thank you again to all of you for coming out today, despite the challenges of the last 6 days. We're delighted that you could attend, and we hope that this will be informational and educational for you. So I'm going to talk a little bit about progressive MS, but I always like to start out with putting up this slide about the cause of MS, because despite what you just heard from Dr. Katz-Sand, how far we've gotten with therapies, having 9 different marketed products out there, we still don't know what the cause of MS is. There's a number of hints, and you heard about it today. We know that there's an immunologic aspect to multiple sclerosis. We think there may be an autoimmune aspect, but we haven't proven it. You heard a bit about vitamin D and viruses and genetic challenges for the disease and environmental challenges for the disease, and from Dr. Casaccia, how they will interact, which is a very important area for future research. And the reason I show this is because despite not knowing the cause, we've gotten as far as we've gotten, especially in relapsing disease, and it gives us great hope in moving forward as we answer these questions, more questions about the cause of MS, that will provide us with even better therapeutic options. So my task is to discuss progressive forms of MS. And there's 2 main forms of progressive MS. The first, which is the top chart there, is what's called secondary progressive MS. And this is the form of the disease where individuals start out with relapsing remitting MS, which is our commonest form. And, like 85% of individuals start out with relapses. But at some point down the road, years if not decades later, a percentage of those individuals will go on to gradual worsening, and that's what we call progressive MS. The bottom graph is the less common, about 15% of the time, of individuals who have what's called primary progressive MS. These individuals never have an acute attack. Instead, they start out as gradual worsening over time, usually involving motor function in the legs. They tend to differ from the rest of the MS population in that they tend to be a little bit older, and while relapsing forms of MS are more common in women than men, in primary progressive, the ratio is about the same, equally affected. And they just start out with gradual worsening, and will come in and they'll say, for the last 6 months, I haven't been able to jog as quickly as I used to, or as far as I used to, or my legs get stiff, or my balance gets off. But when we question them very carefully about any attacks, we don't have any. Now, some of those people may go on and have attacks later on, which becomes an even less common form of MS known as progressive relapsing. But nevertheless, that's the progressive stage of the illness. We worry about this because individuals with progressive forms of MS are more likely to develop difficulties and impairments. And so it makes for a major challenge for us. And the way individuals worsen from the illness are listed on this next slide. And clinically, there's 2 ways. One is, if you have an exacerbation and you don't make a full recovery, you'll be stable until the next exacerbation, but nevertheless, you'll be left with some residual. Maybe the vision isn't quite as good as the eye that had optic neuritis, or the sensation in a leg that started out numb doesn't return fully, or balance or gait may be off. And then the next time you have another attack and have a little bit more residual and this sort of stepwise worsening. And then there's the progressive form where there's just this gradual worsening over time. And I used to say gradual and inexorable, but I'm taking away the word inexorable because I'm going to show you why it's not guaranteed that you will continue to progress. On a pathologic level, that is what's happening to the tissues underlying this, there's two things that we're interested in. One is the inflammation that you've heard about already, and you saw the immune function slide, and I have to tell you that that's a simplified version of the T cells and B cells and blood-brain barrier. And in fact, most of our answers are going to be in the parts of that slide that don't have anything in them, the white parts, because that's where the answers for future therapies are going to be. And then beyond the inflammation, which I'll come back to, there's degeneration, meaning that you're losing tissues, losing either neurons or axons in addition to myelin. And so two of the therapeutic areas that we want to think about, the small print on here is the things that you've heard about or will shortly hear about, things like disease-modifying therapies you just heard from the nice discussion by Dr. Kat Sand, and also how to treat acute exacerbations. You'll soon hear about how to enhance function and symptomatic therapies. But for progressive forms of disease, there's two things we're looking at. And one is a strategy known as neuroprotection. And that is treating with an agent or a technique that will lessen the chance of damage to the underlying tissue. So even if you have the inflammation, we want to turn off the mechanisms that lead to the damage to the myelin, to the axons, to the neurons. And then we'll get to the third category of repair. And so we think that there's a dual phase to the illness. Part of it inflammatory, part of it degenerative. And we don't know yet whether the inflammation leads to the degenerative phase, which it very well may, or if the degenerative aspect is independent of the inflammation, or even if the degeneration starts first and the inflammation is second. And so this is some of our challenge. But we do know the longer the disease is present, the more likely you are to lose tissue. And we've seen that in studies. And this looks a little complicated, but it's not. So this is a graph of the course of the illness. And on the far left are only changes in the MRI, and you heard about this radiologic isolated syndrome earlier, where individuals have changes on their MRI, but nothing clinical. And then the next stage, coming from left to right, is what's called clinically isolated syndrome, where someone has their first attack. At the same time, if you look at the arrows on the bottom, that's the MRI activity. And we know the MRI is more active than what we see clinically. It's a very sensitive tool. So there's been changes that we pick up on MRI that individuals are completely unaware of by symptoms and that we wouldn't necessarily see by examining them. That's the stage we're focusing on now. We want to take individuals at that stage and say, who can we predict is going to do badly and end up with a lot of difficulties and walking problems, cognitive issues, and lots of changes on their MRI, and who's going to go along and do just fine? Because one of the wonders of MS is that of the serious neurologic diseases, this is the most variable, from having hardly anything at all to having very serious impairment, and everything in between. What we don't know how to do yet is at that very early stage to predict who's going to be where. Now, there was a time when it didn't matter because there was nothing you could do. But when you listen to what Dr. Kat Sand presented in terms of those therapies and what Dr. Miller will tell you about future therapies, we're going to have a range from pretty mild therapies that are modestly effective but don't have a lot in the way of side effects to very aggressive therapies that have the potential for a lot of side effects. And we have to decide when and how to use those. We do have the feeling that the earlier we start treating individuals, the better they do. But we have to balance the benefit to risk aspects of that so that we don't treat someone who wasn't destined to have very severe disease with a very aggressive agent. And the converse, that we don't miss treating someone who is going to get aggressive disease by not treating them early on with a very, very aggressive agent and take on the attendant risks that may occur. The way we're going to solve that problem is by developing markers, biomarkers early on, where we look at the clinical picture, the MRI picture, and hopefully some genetic analysis and other analysis of circulating immune molecules that will give us a better hint as to where we ought to be going with that. So that is a major goal now. So we know what we need to do, and we're working towards getting that answer. It's not at hand yet, but we have a kind of clear vision of what it'll take to get to there. And these are some biomarkers which we currently have that are giving us some help here. So if you start at the bottom, you have the JC virus exposure, which Dr. Kat-Sand just explained to you. That's a biomarker. That tells us who's at greater risk or much lesser risk of developing a complication of one of our therapies. It's a very important breakthrough for us in terms of stratifying the risk, mitigating the risk of individuals when they go on to different therapies. Similarly, second from the bottom, neutralizing antibodies help us determine whether a drug is still appropriate for not, because if you have antibodies to the drug, it probably isn't working very well for you. And you heard from Dr. Kasach and others about genetic and genomic screens. And so these are some of the things that we're going to be looking at in the near future and moving forward to try and answer this question of better characterizing the risk of any given individual as close to the time of diagnosis as possible. And here's some work, some preliminary work that we've done with a group of individuals. And this is what's called a genome-wide association screen. And it's called a Manhattan plot for obvious reasons, because it looks like the skyline. And this is the risk of having, this particular one, is the risk of having a low burden of disease, very few lesions on your MRI versus a lot of lesions on your MRI, and the tiny dots towards the top discriminates between high and low. And so we think this sort of technique will give us important information, which it has to be validated yet, but we found some genes that may discriminate between a mild course and a severe course. And this will be, if we can validate this, be very important moving forward. And then we have to think about what's happening in the basic research laboratories, such as those as Dr. Kasach or our other basic science research colleague, Dr. Gareth John, looking at immune function, where there's a lot of work going on, genetics, which you've heard about, environmental factors, you've heard some hints, things like vitamin D. Right now, as Dr. Miller said, and actually cautioned earlier, is an association. It's not cause and effect. But it's interesting, and we're looking at it. Infectious agents like Epstein-Barr virus, also some very interesting associations, not yet cause and effect. And then there's other things out there that we'll be looking at as well. But we know that there's a genetic element disease, and we know there's an environmental element. And now we have to see where the two fit in. My colleague, Dr. Inglesi, is leading work on looking at imaging advances, ways of better characterizing the type and quantity of tissue damage that we see using what are called advanced MRI metrics. And then there's work underway on regeneration and repair, and I'll come back to that shortly. One of the hallmarks of progressive disease that's been a very important discovery of late is that either form, either secondary progressive or primary progressive MS, still has inflammation. This is important for us to know because it means that when we develop our therapeutic strategies, we have to keep in mind that there's still an inflammatory component, even though to date, the therapies that we utilize, which you just heard from Dr. Kat-Sand about, are all anti-inflammatory. They haven't been very effective in progressive disease, either secondary progressive or primary progressive, but they have to be taken into consideration. Also importantly is the amount of damage that occurs in other areas besides just white matter. And here is a slide that shows gray matter disease, meaning that the cortex, where the nerve cells live, and deep in the brain there's also nerve cells, is also involved in the disease. And now we know that there's actually more involvement of these gray matter areas than we thought before. And so it's affecting our therapeutic strategies in that regard. And then when we look at the course of the illness, these are the things that we've been thinking about in terms of dealing with inflammation, regeneration, and degeneration. And the reason why regeneration comes up there is when I was in medical school, we were told that all the cells in your brain, your neurons, were there at birth, and you don't get any more. You just lose them. And for some of us at varying rates, but you lose them, and as you get older, you lose more and more, and this is just the way it is. So it turns out that that's not entirely the case. You can grow new brain cells, and over time, you can repair myelin. And even in late stages of MS, the cells that are needed to repair the myelin are still there. But something's impeding their ability to follow the natural healing process of repair and regeneration. And so some of the strategies that are being exploited now or looking at in early clinical phases and research laboratories are how to enhance your own ability to repair and how to inhibit what's going on within the lesion of MS that stops this natural repair. We also, as I mentioned, are developing new imaging techniques. I put this in because they're very pretty pictures, but they actually have some relevance to what we're talking about, and that is with new MRI techniques, we can look at pathways. So you know there's a pathway. If I want to move my right arm, which I'm doing a lot of, so there's some neurons up here on the left side that send signals down through my brain, through my spinal cord, out to my hand and shoulder to let me move it around. Those pathways are shown on these pictures. So we could pick out individual pathways and try and determine whether the pathway is damaged or not. If it is it damage to the myelin, which would lead to one strategy, or is it damage to the underlying nerve fiber, the axon, which you heard about earlier today, which would lead to an entirely different strategy. So with imaging, we can get a better idea of what's underlying the disorder. Normally, you would need a pathologist to cut the brain up and tell you the answer, but at that point, it's really too late to do you any good. So the MRI is a major step forward for us. And then I mentioned this idea of remyelination, and we know that it occurs, and we just have to develop some strategies, which I'll show you, on how to enhance the ability for remyelination to occur. Now, I mentioned something about not inexorable. So progression is not inevitable. First, not everybody develops progressive disease, only a percentage. And we think, and I think you heard this earlier, although we haven't proven this yet, we have a pretty good feeling that since we started treating the illness now for the last, it'll be almost 20 years, that we're seeing fewer patients develop secondary progressive MS. But even the ones that do, and primary progressive, don't necessarily continue to progress. And so this is some work that my colleagues did at the center, looking at what happens when someone came in and we talked with them, took a history, examined them, and said, you know, you've got primary progressive MS, you've got secondary progressive MS, and looked to see how they looked over the next 3 to 5 years. And what we found was that about a third of them looked worse, but 2/3 of them didn't. They hadn't changed very much at all, and there's just two different scales here. And on this scale, which is walking speed, so those of you who come to visit us at Mount Sinai know that every visit we time your walk. We get the stopwatch out, and we encourage you to walk as quickly and safely over 25 feet as possible, and we have a little area marked out there that you walk on. And it turns out it doesn't always get worse. And in fact, in some of the individuals, it got better. The majority of individuals, it didn't change, and only a portion of individuals actually worsened over time, meaning that the characterization or the description of having progressive disease doesn't guarantee that you're going to progress. It really is part of the mystery of MS is that it's still very variable. And that has important implications in saying this is not guaranteed to cause you more difficulty, but it's also important for us when we design clinical trials so we can pick the right population to apply our therapy to. Because if you apply a therapy to people who aren't going to progress, you'll never be able to show that it works. And so some of the things are going forward. So there is a big push to look at progressive disease now. The National MS Society has made it a major part of their strategic plan. There's an International Progressive MS Collaborative, which involves the National MS Society here, the Canadian MS Society, the British MS Society, the Italian MS Society, and then the Multiple Sclerosis International Federation, which is a group that includes all of the worldwide MS societies, to start to look at how can we better study, treat, and find funding for trials for progressive MS. and that is underway now. They just had a meeting in London earlier this week, which I attended by teleconference because I couldn't get to London, which actually was okay. But to try and develop the metrics for looking at progressive disease and also develop the strategies for better treating it and also for better funding studies so that this can be solved more easily. And there are trials underway. And so let me just say, so phase 2 trials are proof of principle trials. They're early phase trials where you pick some metric of the disease and study it over a short period of time to get an idea whether an agent works or not. A phase 3 trial is a pivotal trial, which if you succeed, and it always has a clinical outcome, then you can apply to get that drug or procedure approved by the FDA or the European Medicinal Authority or Health Canada or whoever's going to license your agent. But those are the pivotal studies that lead to products being approved. And so right now there was a phase 2 study of simvastatin, which was interesting, a statin drug, lipid-lowering drug, that my colleagues and I heard presented 3 weeks ago at the European MS meetings. It looked very promising as a proof of principle. They succeeded, looking at changes in the amount of damage done in the brain, the volume, whether the brain shrunk more or less, whether you're on the drug or not. So it's an interesting result, needs to be confirmed, needs to be looked at in a phase 3 study. But it was exciting because it was a successful trial design, and that's very important for us moving forward. There's also a phase 2 trial of a drug called saponamide in secondary progressive MS, which is ongoing. Saponamide is similar to fingolimod or Gilenya, which you just heard about, but it's a little more selective. There's a pivotal trial, phase 3 of ocrelizumab, which is a drug that it removes certain types of B cells from your circulation, and had a very successful proof of principle study, phase 2, and now it's in phase 3 for primary progressive MS. Fingolimod you heard about in relapsing remitting, well, that's also being looked at in primary progressive MS. And there's a trial of natalizumab, Tysabri in secondary progressive MS. So this is the most trials we've ever had ongoing for progressive disease. And so that's pretty exciting. And there's some new strategies coming along as well. So some of these new strategies include stem cells. And I'll tell you a little bit more of that. So there's been some interesting work done in stem cells. We did one study here using placental stem cells in a very early phase study. It turns out the placenta is a very good source of stem cells. You can get many millions from a single placenta, and they serve similar purposes to other types of stem cells. We did an early phase study, and the safety looked okay, and we're hopeful we'll move forward. There's also another type of stem cell called mesenchymal stem cell, which is being tested at this seminar. I guess it was 2 years ago, maybe 3. Jeff Cohen from Cleveland Clinic discussed his plans for a mesenchymal stem cell trial, which is now underway. And so that's of interest. The stem cells are interesting because we're not yet sure whether the stem cells are going to do the replacement or whether, and this is more likely, the stem cells enhance your ability to repair themselves. And so that's going on. There are other ways of enhancing endogenous repair, that is molecules that improve your ability to repair your own damaged tissue. And those studies are underway. In terms of neuroprotection, we're looking at antioxidants, and I'm not talking about the stuff that you go to the health food store that has a whole counter there that says antioxidants. I have no comment about those, but I'm talking about targeted molecules that will affect what are called mitochondrial function, which is the energy-producing portion of cells, and that's part of the neuroprotective strategy. We're not sure yet where anti-inflammatory agents, like you've heard about thus far for relapsing MS, are going to fit in, but I suspect they'll have a role somewhere. And then we have to start thinking about staging, that is, stop the inflammation first, then stop the nerve damage, then we can enhance repair. But it's probably not a good idea to try and enhance repair if you haven't turned off the damage, because then you're kind of like running in a circle. One of the interesting things about multiple sclerosis is that it bridges 2 domains in biomedicine. One is the inflammatory side, which you've heard lots about, and the other is the degenerative side. So things that we utilize have also been of benefit in other disorders like type 1 diabetes, inflammatory bowel disease, Crohn's or ulcerative colitis, autoimmune thyroid disease, psoriasis, and some of the same principles occur. There are some differences, and some of the medicines for those conditions are actually not good for MS, but others are. And so things that happen in those diseases, things like rheumatoid arthritis, get translated to MS. That's where the B-cell strategy came from. It was initially successful in rheumatoid arthritis, and now it's been translated over into multiple sclerosis, and the reverse. So Tysabri is now used for inflammatory bowel disease. And then we also have the degenerative side where we're looking to work with our colleagues working in Alzheimer's disease and ALS and Parkinson's, Huntington's, and other disorders of the nervous system where there's more degeneration and less inflammation, and see where we can trade off molecules and strategies. We have the advantage of having better trial designs than those areas, and they don't have therapies. And we do. And so there's some interesting intersections there that we hope to be able to exploit. And then I talked about repair and the idea of stem cells, which is our best shot right now, but it's not our only shot, and we don't know how that's going to pan out yet. There's still a lot more work to be done, both proving efficacy and establishing safety. And I told you about this. And so this is what we do when we're not just spending our time taking care of individuals or teaching and such, is to try and take the molecules that work for our basic science colleagues and bring them over to the clinic and test the strategies so they could develop better therapies. And with that, I thank you.
Dr. Lublin is not going to be able to stay for the panel discussion at the end, so we're going to take a few minutes now if there are any questions for Fred.
The question was, what are the political implications on stem cell research? And obviously, they've gotten better over the last 4 years. They're not as good as we would like. And in fact, the science is moving faster than the politics. And so the science is moving away from embryonic stem cells, which is where the controversy was, into induced pluripotential cells, IPC, which is taking even a skin cell from an individual and turning back its programming till it becomes a stem cell. And then it can be regenerated into something different. So the science is moving faster than the politics, and that's probably a good thing. Okay, so the question was, what's the time frame from a successful phase 3 trial to a drug release? So it usually takes 2 successful trials to get through the regulatory agencies, and then they take a minimum of 6 months if they fast-track the drug to approval, and usually longer. And some see that as an impediment, but in fact, at least here, the FDA actually does a very good job of this. They review the data for themselves. In other words, they don't take the results that the companies give them. They take the actual data points. It's like a 1,000,000-page filing that they get, and they put those data points into their computers and run their own statistical analysis. They come out with the same result that the drug worked, and they also find that it's safe, then it gets approved. Usual time frame from phase 3 to approval averages about 18 months, sometimes a little quicker. But it's a good assessment, especially on the safety side. It's a resultant. So the question was, is the mechanism that affects repair what causes MS? I don't know the answer. So it's a result of whatever it is that causes MS, that it affects the repair. But whether it's one type of cell dying out or another cell not regenerating properly is not yet clear how that relates back to the cause. It's a good question, something to think about. Sure, it's being tested. So once a drug's in clinical trials, there's nothing to say. There's a quiet period until it's done. We don't look at the results as we go along because there's reasons why you can't do that. It makes for an invalid study. You have to lay out your question, do the whole study, and then at the end you look at the result. You can't look at it sooner. So we just don't know. We're still studying it. So methotrexate injected in the stomachom has never been studied in a clinical trial. So I have no thoughts about it. Rituximab or Rituxan has been studied in clinical trials in what were called the phase 2 trials I talked about. Very successful for phase 2. Unfortunately, the companies that were involved...
In relapsing disease.
Sorry?
In relapsing.
I'm sorry, yes, in relapsing disease. Thanks. But that's not going to go into phase 3. The next generation of that type of molecule, which is the ocrelizumab, which I had on my slide, and you'll hear more from Dr. Miller about, is in phase 3 testing right now. You'd have to ask the pharmaceutical companies why they chose not to.
Dr. Lublin, we have a question.
A pharmacopolitical decision.
We have a question right here.
Yeah, I've heard of some neurologists outside the United States that advocate bone marrow transplants for the treatment of MS. Can you address that, please?
Dr. Miller is going to discuss that. So I said remyelination occurs. It occurs all through the illness. So you damage myelin and you repair myelin. What happens over time is that you lose the ability to repair again. So early in MS, there's a lot of myelin repair. Later in MS, that repair gets inhibited. And it's one of our therapeutic strategies that we're thinking about, is how to stop that inhibition.
Okay, tissue repair. How can you repair myelin if you can?
I'm sorry.
How can you repair myelin if you can?
Well, you can't. And so like I said, early on, there is repair that goes on. Later on, it's inhibited. So one of our strategies is to try and take away whatever the molecular basis is for that inhibition.
And I'll have a little bit more to say about that as well.
Good.
Okay, I think we better move on. Thanks very much.
Thank you all.